afternoon, everybody. All right, that is my name, Peter Muchina. I'm a final year student from Moi University, and I'm going to present to you a case that I did when I was finishing fourth year. Present it as a story. Hope you just are attentive for the next 5 minutes, and then we'll be done. Okay. All right. So that is me. That is what I've been doing in life apart from studies and dentistry. I hope to add more as time goes by. So this lady is a 20-year-old lady who works into MTRH sometime in 24 after she had her a jaw surgery, during which she lost half of her mandible, the whole of the fourth quadrant, and she lost from the 4-2 all the way to the 4-8. This is following an ossifying fibroma, which was removed in 2023. And when she walks into MTRH, she's told, we don't have a prosthodontist here. Kindly go to dental school and you'll find one there. And she finds me. I'm not a prosthodontist, but by faith, I take up the case. I go discuss it with my lecturer, Dr. Toka, and he tells me, I'm behind you, we can continue with this case. And so with that blessing, I continue with the case. This is the intraoral view of this lady. You can see after the resection of the mandible, there is no alveolar bone on that side. Actually, it was flush with the floor of the mouth, and it presented a lot of problems for me as a starting student in fourth year on how I was supposed to go about this. So, but anyway, I had help. And this, you can see, if you note from this side, there is no back of fullness on this side because she doesn't have the alveolar bone to provide that, in contrast with the other side, just to appreciate. So we took a primary impression. Of course, in dental school, we don't have digital and all that. We still use Hygiene. So I took a primary impression. You can appreciate the mandibular primary impression, showing the area with the resection. And these were the resulting primary casts. And you can see on the mandibular area, there is nothing, completely nothing on the fourth quadrant. Fabricated a special tray with a spacer, especially for the mandibular one sheet wax thickness of spacer, and made a special tray, perforated it so that I could take a secondary impression for it. And treatment planning, and this was the treatment planning. The main thing to overcome the challenge of retention, we decided to use aggressive clasping on the remaining third quadrant in order to get retention, because in this case, we don't have alveolar bone to provide any kind of retention. So we have to use what is remaining to provide retention, and that was our treatment planning. And we prepared rests on 3-4, 3-5, 3-6, and 3-7. Of note, our rests were not what is normal. We extended them to cover about 3/4 of the occlusal surface so that we get enough retention for this case. And this was the secondary impression using the dual viscosity technique, the light body taken over by the heavy body condensation silicone, which is basically what we use at school. Redid the primary impression for the maxillary so that it looks better, and the mandibular, that is what it looks like. And this was done after preparation of the rest seats, as you saw on the treatment planning. All right, and this was the metal framework try-in the mouth. You can appreciate that actually we were able to reproduce some kind of occlusion, although it was completely not possible. We may have lost about 0.5 millimeter, but we were satisfied with the occlusion that we regained. And here we did bite registration, fabricated wax bite on which she bit on, and then achieved occlusion again. Send it to the lab. We were using an external lab, not the school lab, and they were able to set those teeth that way. We used shade A2, and from that try-in the mouth, you can actually appreciate the reproduction of aesthetics, especially in the shade. And this is how it looks in the mouth with the mouth closed. Not on the right, lack of back of fullness. It is restored in the left one when she has the prosthesis in the mouth. And we were very happy with that. I was happy with that. And then The challenge that we were facing after having achieved that is that after surgery, she lost keratinized mucosa from the alveolar bone that she ought to have had because the buccal mucosa was sutured directly into the floor of the mouth. And so if you put hard acrylic on that, you'll have a lot of ulcerations and a lot of problems. So we had to do a resilient soft liner on the fitting surface on that denture. And so we used, if you can remember, the McLean impression technique for the prosthodontists who are here and you can still remember. Zinc oxide on the impression on the fitting surface of it, and then an over impression using an oversized stock tray, and then withdrew the whole thing as a unit and then sent it to the lab so that they could fit the fitting surface with the resilient liner. It's very soft so that it is friendly to the non-keratinized mucosa that she now has on the resected side. And this was the final prosthesis. We used an IBA for the remaining 4 1-tooth retentive clasps, a lingual plate, rests to cover all the posterior teeth on the contralateral side, reciprocating clasps on that side, not the resilient soft liner. If you can trace it and contrast it with the acrylic base that is there. And I've been in touch with the patient ever since, and she's very happy, and I'm also very satisfied. Probably I could consider becoming a prosthodontist in the future after this one case. But that was my case after 4th year, still looking to do more and achieve more. Thank you.